You are listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Badve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, everyone. I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today, we're going to delve deep into HER2-low. Is this really distinct biology? Is this an artifact of testing? Do we care? And how do we know that we're getting reliable results? Now, if ever there was a topic that called for an expert pathologist, it is this topic, and I am delighted to introduce you to my guest. Dr. Sunil Badve is professor and vice chair of the Department of Pathology and Laboratory Medicine at Emory University and a staff physician in the Department of Pathology and Laboratory Medicine at Emory Healthcare in Atlanta, Georgia. He is one of the world's foremost breast cancer pathologists. Sunil, thank you for joining me.
My pleasure, Kathy. Thanks for inviting.
So before we get to HER2-low, take me back to the beginning and help us think about HER2 testing. There are some institutions that use IHC, some still go directly to FISH. Do we know what is more reliable or more reproducible?
Thanks, Kathy, for the question. As you all know, the discovery that HER2 was important in breast cancer came from some papers from Dr. Dennis Lehman's lab in collaboration with Dr. Mike Press. And they basically identified that HER2 was a poor prognostic factor in breast cancer. And the test that was designed at that particular time was the FISH assay. And then there was a move to develop IHC assays. And the first, there was the clinical trials assay. And then for a long period of time, there was the Hercept assay. And all of these have been developed and validated in clinical trials. So as you well know, the BCIRG trials always use FISH as a selection criteria, while the B31 and 91 pivotal trials have always used IHC. And there's always been back correlation between the two assays, and both seem to be extremely good at selecting patients who are likely to benefit from therapy. Obviously, there is not 100% correlation between the two, and there are some cases on either side that are IHC positive, FISH negative, and FISH positive, IHC negative. So which is better has been always a question, but the data from the clinical trials seem to suggest that either of the assay is good for selecting patients for therapy.
Now, this is such an important topic that ASCO and the College of American Pathology got together to develop some quality guidelines, and they introduced a new term of equivocal results, which I understand, but the term seems to bring a lot of confusion because the term seems to imply that we don't know or there's some uncertainty. So when ASCO-CAP uses equivocal, what do they mean by that? What should people in the clinic do with those results?
So when HER2 was first introduced, and we knew that there was a toxicity related to the heart, and people were doing echocardiograms, and there was such a lot of concern that anybody who we are not 100% or 110% sure is HER2 positive, we should not be giving those kind of patients therapy. So a lot of these concerns led to the development of these equivocal criteria, which basically said, I think it's positive, but let's do a second assay to double check that it's truly positive before we give the patient a fairly toxic drug. As it turns out, Herceptin is not that toxic. But if you see the history of the ASCO-CAP, the first ASCO-CAP guidelines even tried to raise the IHC level to 30% positivity by IHC in order to get a better concordance with FISH and be absolutely sure that positive is really positive. Then, of course, as additional data came along and the fears that we were overtreating patients or possibly overtreating patients receded, the concern became more about not treating patients who are positive because the drug turned out to be remarkably efficacious as well as not that serious in terms of toxicity profile. So the second version of the ASCO-CAP brought the cutoff point for IHC back to 10%. And again, the equivocal term has kind of persisted for those borderline cases where you feel unsure that the test is giving you the exact result that you expect. So for example, we are using for FISH a score of 2.01 as a ratio between the number of copies of HER2 to the number of copies of the control gene, which is CEP70. Now, when it is just over the border with such a small ratio, one is always concerned that, well, is this truly positive? Is this patient likely to respond? Or am I treating somebody with little or no benefit? And those are the kind of cases. Same thing with IHC. We had the 10% cutoff. What if it is 9% or 8%? How sure are we that 10% is actually 10 and not 11, not 9? So all of these concerns really raise the issue of having something where we can go back and do a second test to confirm the results and then be absolutely positive that the right patient gets the right therapy.
So it's fascinating how the perception has changed over the years from a default to saying we only want to consider HER2 positive and the people who are really positive so that we don't treat people who might not benefit, to realizing this is really effective therapy and shifting the default to we want to make sure we get this therapy to all of the people who might potentially benefit, even if that means bringing in a few that don't.
Absolutely right. Again, as we will talk about in HER2-low, we are talking about even lower levels of expression than the classic FISH-positive IHC3 plus cases to talking about lower degrees of positivity.
So even though pathologists would give us the HER2 scores and the FISH ratio, in clinic notes, it usually got boiled down to it was HER2 positive or HER2 negative. But we now have to consider HER2 low. So what does that category mean to a pathologist?
So what has happened over the years is we have novel drugs that have come along. And these drugs not only target the cancer cell themselves, but they also target the neighboring cells because the toxic agent sips out of the cell and attacks the neighboring cell. This bystander effect has resulted in lesser degree of positivity being required for patient to be eligible for therapy. And so we no longer require the FISH positive cases only or the IHC3 plus positive cases only to be eligible for HER2 targeting. What we are now realizing is that some of these newer agents work extremely well in cases that have FISH negativity as well as not IHC3 plus, that is non-traditional cases are now considered as HER2 positive. So when the IHC assays were first being developed, we were trying to separate the high mountains from small non-mountainous hills and molehills and things like that. As the drugs have improved, now we care not only about the mountains, but the hills and even perhaps the molehills that are there. And these lower degrees of expression, those patients in clinical trials have been shown to respond to therapy. So all of this has resulted in this new category called HER2-low, where we still have the CAP cutoff of 10%, but we have a lower intensity of positivity. That is, we have 1 plus positivity, 2 plus positivity. So what is 2 plus and 1 plus? It means it's just weaker degree of expression when we are doing an immunohistochemistry assay. Classic HER2 3 plus positivity is like a chicken wire or those kind of dense membranous pattern of staining. Here you get a focal membranous pattern of staining and those kind of weaker intensity. The chain link, so to say, is not complete. There are partial membrane stainings. So these kind of situations are also now observed that the drug is efficacious in patients with tumors who have these low levels of expression.
So this really became important with trastuzumab deruxtecan that had significant activity in the HER2-low patients, so 1 plus or 2 plus by IHC, but FISH negative. But there have been other agents that tried to find a role in this category, or at least the 2 plus FISH negative, and they really were not successful. Do we know what's different about this new agent that got us over the hump, so to speak?
Well, again, I'm not a pharmacologist, but what I'm told is that the new agent has got two additional features from classic trastuzumab. One, of course, is the toxic agent that is piggybacking on the antibody. And there seem to be 8 molecules, not 1, not 2, but 8 molecules of these toxic agents that are piggybacking. They not only kill the cell that is HER2 positive, that is where the antibody is attaching, but as I mentioned previously, they sip out from this dying cell into the neighborhood and also cause bystander effect. And this has been the major transformational change in terms of the increasing efficacy of the drug. So number of potent molecules as well as the ability of those potent molecules to escape the cell and kill the adjacent cells, which may or may not be HER2 positive.
The others that I can think of were not antibody drug conjugates, so they were really still dependent for activity on HER2 being a driving factor. And here we're really just using HER2 as a mailbox to deliver the therapy and then potentially get that bystander effect.
Absolutely right. So not only we driving the truck through the wall, but the truck is loaded with explosives, and then it causes a big bang, which is what we see in terms of therapeutic efficacy.
So Sunil, just when we thought HER2 testing couldn't get any more complicated, there's now another new term, HER2 ultra-low, from the most recent DESTINY trial. Help us understand what's ultra-low and why do we need to care about that instead of just HER2-low?
That's a great question. When you see some degree of expression is enough to get therapeutic efficacy, the question basically is, how low can one go? And so the DESTINY-06 trial enrolled patients that had less than the classic 10% requirement. But there was some staining there. It was maybe 1%, 5%, 8%. Those kind of staining patterns were noted, and these patients were treated in this DESTINY-Breast06 clinical trial. And what was observed was that their response rates were identical to the response rate seen in HER2-low patients. So that brings us back to the question, why did we ever have that 10% cutoff? Where was the science behind it? Turns out that the original CTSA assay, the clinical trials assay that was used in the late 1990s, the concordance between it and the Hercept test was best at a 10% cutoff. And that was the reason why 10% was used as a cutoff by everybody else. So that was the FDA filing. The 10% was used for initial clinical trials, and that then followed up with ASCO-CAP accepting it as a cutoff. But this is entirely based on correlation between two assays. There was no real scientific data to talk about 9%, 8%. And maybe it wouldn't have worked even then because the drugs were not as potent. But now when we have extremely potent agents, we seem to be seeing that even a itsy-bitsy bit is enough to cause therapeutic efficiency.
So Sunil, my clinical colleagues are now going to be looking for those itsy-bitsy bits. And there are going to be a couple of questions. One is there are several different HER2 antibodies that have been used historically and that are still available. If you're looking for itsy-bitsy bits, does it matter what antibody you use?
Actually, that's a great question. And to be very fair, AstraZeneca and Daiichi have been extremely interested in this particular question. And they have basically used an international study group, a ring study, using multiple antibodies on the same cases. and try to understand whether antibodies really make that much of a difference. Because as you know, some of the initial trials were done using the Ventana antibody, the 4B5, while the Destiny-06 was done using the DACO antibody. And it turns out that different antibodies have different sensitivity, but by and large, they all seem to be doing a good job. Now, there are obviously some antibodies that we have not talked about that are quite awful, but we knew that they were awful for a long period of time. And so therefore, many of them have never really found widespread usage in clinical practice. So long as you're using the commonly used antibodies from the common makers, that is DACO, Agilent, or Ventana Roche, you're fairly okay in terms of getting very similar results.
Now, the other question that will come up in the clinic, besides searching for the pathology reports, because we just summarized them as positive or negative in our notes, if my patient's pathology report just says HER2 negative or HER2 zero, do I need to go back and ask the pathologist to retest them to see if this is one that had the bits?
Absolutely. We, in our routine reporting now, since Destiny-06, have clearly started saying, even if it is zero, putting a comment saying no staining at all or focal staining is noted. So making it absolutely clear, right from the word go, what is the level we are talking about? Because it makes life easier that you don't have to chase it in a retrospective manner. Obviously, this data came in June. So before that, we had no idea that what's considered CAP0 will now be split into focal staining and no staining at all. But we have to go back. Obviously, if you have a patient with metastatic disease, getting a biopsy closer to the time of therapy would be ideal. But it seems like any positivity at any stage in the patient's tumor cycle is sufficient to be selected for this particular form of therapy. Because the enrollment of the trial consisted not only of biopsies from metastatic tumors, but also from old biopsies and excisions from the primary tumor. So we don't necessarily need to worry about getting the latest biopsy. Any positive result at any period of time seems to be sufficient for the patient to get enrolled or prescribed this particular form of therapy.
So, Sunil, I know there were some laboratories that skipped doing immunohistochemistry and preferentially did FISH testing. That feels like a problem.
Yes, and that really is becoming a problem. But at the same time, if you have a traditional FISH-positive patients, those patients can be given THP and other regimens that are supposedly less toxic, as opposed to TDXD, which is supposedly more toxic, requires more monitoring. So there are people who still think that they would do the FISH first. If it is positive, they have a different regimen they will use. If it is negative, they will use the other regimen. So as you know, the Compass HER2 clinical trial is just about finishing. It should report fairly soon. So that was a question that was being asked of us in the ECOG folks as what would happen and how would the impact of Compass HER2 matter in the era of TDXD. And clearly there seem to be thoughts that THP might be less toxic than TDXD, and there may be still room for more agents within the HER2 space than just TDXD.
Certainly for the FISH tests that we would all agree are positive. That's actionable information for any clinician and any of the therapies we've been talking about. But we don't know how to identify the ones that have the itsy bits with just FISH testing. That's also going to be a call to our friendly pathologist to ask them to take another look and do another test.
Absolutely. I mean, more and more, the data now today is that we have to do IHC, no matter how much you believe in FISH. And that's really the loud and clear message coming on from the Destiny trials, whether it's 04 or 06, that IHC is critical for identifying that low level of protein expression that is there on the tumor cells. That is where the antibody binds, and that is ultimately going to decide whether the drug is going to be successful or not.
So, Sunil, we talked before about the concordance between IHC and FISH, but there's another important concordance between one pathologist and another. How good are the pathologists in giving us the same results? And is that more difficult when you're looking for the itsy bits rather than the screamingly high cases?
I think this is really important. There's plenty of studies that have shown that the concordance between pathologists for distinction between 0 and 1 is difficult. And I do believe that some of it is because of lack of training. Some of it is because the questions were poorly framed, because people were still not quite aware about the differences between 0 and 1 in terms of therapeutic benefit. But I do believe that as we get into this ultra low, finding something versus nothing is a lot easier than saying that there is 1% staining or 5% staining or 9% staining. If it is clean negative, that's your negative, 0, null, no staining at all, whatever you'd call it. Then there's some staining, whether it's minor degree, 1 degree, 5 degree, 20 degree, whatever the percentage intensity may be. And there's oh my God, this is completely brown staining. And I think that as we get into these 3 categories rather than the 4 categories, we will get an increased amount of concordance between nothing, something, and hell of a lot. And I really do believe that we will see that kind of data in the near future as studies are being done. So I hope the fears about concordance recede rather than increase.
It's interesting. I think you just said we tried to make the pathologist's job too difficult in the beginning, and it just got easier because if you see a little brown somewhere, you're done.
Exactly my point. And that's really what makes me happy about the Destiny 06, because I believe the concordance between pathologists is going to be improved and clinicians would have lesser degree of fear in terms of understanding, is my pathologist calling the results right?
So, Sunil, I have one last question for you. In your heart of hearts, do you think there's really a distinct biology to these HER2-low and ultra-low cases, or have we really just been struggling with artifacts of testing and where we put artificial barriers in test results?
I think biologically that we just have 2 types of diseases, ER positive and ER negative. HER2 is wonderful because it's a good therapeutic target, but I don't think it's that critical in terms of defining classes of breast cancer. If we didn't have trastuzumab, we didn't have TDXT, we wouldn't care about HER2. But all of these ADCs that are coming around, we are going to have different molecules that are present on the cell surface that lends themselves to targeting by antibody-drug combinations. For example, sacituzumab, which is used in triple-negative patients, that protein is expressed on a lot of breast cancers, whether they are ER positive or ER negative. And it has shown to have utility because of that very reason that is present on the surface. So I do believe that it's a protein that is expressed as one of the mechanisms of resistance to therapies. When I was at Northwestern more than 20 years ago, did a study with the late Craig Jordan, and we basically showed that tamoxifen resistance led to an increase in HER2 positivity. And that has been, of course, replicated multiple times. But this seems to be one of the common mechanisms of resistance. And so it's a small surprise that metastatic tumors are often showing low levels of HER2 positivity. So I really do not believe that this is a separate entity. It's just a nice little hook to catch the tumor cells by and fish them out and kill them.
Today, we've been talking with Dr. Sunil Badve about HER2 testing and the importance of identifying HER2-low patients and those with ultra-low staining. This is going to require us all to become more familiar with testing yet again, to talk to our pathologists and to make certain that our pathology colleagues are giving us the detailed results of what they're seeing on the immunohistochemistry so that we can make sure we identify all of the patients who may benefit from these very powerful HER2-targeted ADCs. Thank you all for tuning in with us, and please take a moment to download the Medscape app to listen and subscribe to this podcast series on HER2 breast cancer. This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.